The issue of biomarkers we talked about a little bit at the last meeting. There have been some significant developments in the last few years. There will be significant developments going forward, and so I was hoping just to give you a little bit of an update on. Where do you have to point it?
Oh, well now.
Oh, now we're on the other one. Okay. This sort of illustrates the schema of damage to the kidney, both acute injury to the kidney and chronic injury to the kidney. And if we start with a normal kidney, the kidney can be acutely injured to a variety of extents and degrees and severities, from a little bit of dysfunction to major structural alteration, then all the way to kidney failure. This is the way we have sort of historically looked at acute kidney injury. We've called it acute kidney failure because that's the stage that we customarily view this development. But it has to go through this pathway before it gets to that pathway. And if you're dealing with kidney injury at this stage, you might have opportunity to therapeutically intervene to alter the course of the pathogenesis so that it doesn't get to there. The problem is it's very difficult to sort of recognize in many cases when the kidney is damaged at this more subtle stage or at an earlier stage of this pathogenesis. Once the kidney is damaged, then it has a couple of courses. It can not recover. The patient can not survive the loss of renal function. It could completely recover, at least functionally or the way that we would ordinarily recognize kidney function. And after that recovery, then there could be some progression to more advanced stages of chronic kidney disease, or the kidney may recover to some more advanced stage of chronic kidney disease. What we'd really like is to have some diagnostic information that would tell us where along this spectrum you're dealing with your disease process, and particularly for acute kidney injury, could we have some earlier identifiers that would let us know that the animal's in the ICU and it's getting this drug and that drug and maybe not getting enough fluids or getting all kinds of different modalities of therapy. Am I beating very hard on these kidneys, and should I alter what I'm doing at this stage of involvement? When we look at acute kidney injury in terms of its pathogenesis, it's usually defined in phases, where there's the initiation phase where the injury occurs, and that usually is minutes to maybe hours, sometimes days, and subsequent to the initiation phase where the insult that is bothering the kidney may have come and gone. The animal drank up 25 mils of antifreeze. That happened, and now it's in past history, and it's not an ongoing event. But the result of that initiation process then continues on through an extension phase when most of the major pathological and biochemical consequences of the injury become manifest. And then the patient or the kidney will go through a maintenance phase where there's some degree of ongoing damage, and then there's this major attempt by the kidney to try to repair that damage. The extension phase is usually days, maybe weeks. The maintenance phase can be weeks to months. And this can be a very long period of time. And subsequent to that process, then the kidney could go on and recover, or the kidney could not structurally recover and would be lost. Looking at it from a pathophysiologic standpoint, then what happens in these very early phases of the disease, we get disruption of the cytoskeleton of the tubular epithelial cells. There's loss of the brush border and reorientation or disorientation of the cell, loss of polarity, redistribution of transporters, and once you start losing the intracellular architecture and scaffolding, then a transporter doesn't know whether it needs to go to the luminal side of the cell or the basolateral side of the cell, and it gets very, very confused, and then transport processes start going in misdirections, and then the cell and the function of the epithelium that cell is associated with becomes very disrupted. Ultimately, then we often get lack of adhesion of these cells to the basement membrane. They slough off the basement membrane into the tubular lumen, and then ultimately these cells may undergo apoptosis or necrosis and then be lost. During the recovery process, and thank you, Dr. Langston, for this nice cartoon. During the recovery process, you have a bunch of surviving cells that now are injured, sublethally injured, and they need to provide these are the parents for all the daughter cells that are going to repopulate and make the nephron work. And so we end up with these little surviving cells, and so in this one here, this is obviously most of the epithelium has been sloughed off. We end up with a basement membrane that is sometimes covered by a surviving cell that looks very immature and very non-functional. There are big areas of the basement membrane that have no covering at all, and it's these cells then that have to proliferate and then ultimately mature to develop a functional epithelium that populates the entire nephron and regains functional integrity. The other thing we would like to know is there some way biochemically or diagnostically that we can find out where along this process the injury lies, so that would help with prognosis, it might help with therapeutic intervention. And the role for that, the most likely role for that ability to get this perspective is with the use of some biomarker, some detectable element that would be specific and predictive of where you are. And currently what we have a whole bunch of conventional biomarkers that we've been using for 100 years that give us some perspective of whether the cell is sitting here or whether the cell is sitting here. These have some utility. I'll go through just one or two of them. But the real promise appears to be in the development and the validation of novel biomarkers that can more specifically target and pinpoint the kind of damage and the stage of damage that the kidney is existing in. So I'll talk about a couple of these just because we have some data, and then give you my experience in collaboration with the group at IDEXX and Abbott, where we looked at some of these biomarkers to show you what we currently understand about how they might be useful and how they might be in your future for predicting this kidney disease. One of the important ones that we have used maybe for more than 100 years is just simply urine production. The problem with these conventional biomarkers is that they're useful, but they're not very sensitive or specific. We generally suggest that all urea can be a marker. And we would consider a urine production in a hydrated animal of less than, particularly in a dog, of less than 1 ml per kilo per hour, or anuria over an hour, over a period of time of 6 hours, is suggestive and predictive of acute kidney injury. In fact, we're so confident in this that it's become part of the IRIS grading for acute kidney injury. The problem is that an acute kidney injury can generate either anuria, oliguria, or polyuria. So it's not very specific for our needs, and it has variable prognostic significance, because just because an animal starts to make urine doesn't necessarily mean that that kidney is any better off than it was before it wasn't making urine, or that it's going to go on and recover. But in some studies that we've done where we've looked, mostly these are dogs, this is a series of 10 dogs that were generally dogs with acute leptospirosis, and urine production, or the ability of the kidney during a 7-day window of observation, was fairly predictive of animals that would go on to recover. So these animals that remained oliguric or anuric did not survive, or certainly did not go on to leave the hospital, either because they were dialysis dependent or whatever, versus animals that did illustrate an early onset of an ability to generate urine. These animals did survive. But again, this is very, very non-specific and not terribly helpful. Another biomarker that we've used historically is urine-specific gravity. And if you look at urine-specific gravity correctly and often, and it's not associated with other kinds of interventions or drugs or circumstances that would otherwise alter it independently, urine-specific gravity, as illustrated in this gentamicin model of acute kidney injury that we've been doing at the University of California, looks like it pretty well can identify injury, and I'll show you in a minute, much before our historical biomarker like serum creatinine would predict it. And so, you know, if you're following trends in urine-specific gravity and you see it goes from here down to here in 2 or 3 days, that could predict that your kidney is not working very well. And obviously, as you start to regain concentrated function, that can help predict that the kidney is repairing. So that was, the previous was an example from one dog, but when we look at all 5 or 6 dogs that we had in the study, very, very consistent trends. Urine-specific gravity, when it's not compromised by other interventions, is reasonably predictive that this kidney has been damaged. Serum creatinine has been our most familiar biomarker that we've used. It's useful because it's a surrogate for glomerular filtration, which historically has been considered kind of the gold standard measure of functional capacity of the kidney. It has this sort of exponential or curvilinear relationship with GFR, which makes it a bit problematic. And most of the classification schemes that have been developed to stage or classify acute kidney injury actually are founded on serum creatinine. And IRIS would suggest that if you document sequential increases in serum creatinine as little as 0.3 milligrams per DL over a 48-hour period of time, that defines an acute kidney injury. So creatinine is useful, but it again is not very specific. It's, as I'll show you in a minute, it's going to be a very late marker. And so here, back to our gentamicin study in dogs. These dogs were exposed to gentamicin at day 0, and creatinine by IRIS criteria didn't identify the acute kidney injury until probably 14, 15 days after these animals had been exposed to that nephrotoxin. And then the animal went through progressive stages of grades of AKI and ultimately recovered. But this was a late marker of acute kidney injury, and certainly we would have liked to identify that these kidneys were injured, and maybe we ought to modify our gentamicin administration way back here at day 2 or day 3 or day 4. All right, so what are we looking at in a biomarker that's going to be useful for us to help predict whether the tubular injury is here and it's going in this direction, or at what stage it is? A biomarker we would like to be something that can be routinely assayed in either urine or plasma, that's a constituent of urine and plasma, that can serve as an index or an indicator of dysfunction or damage or recovery of these renal cells. It must be very specific for renal events. And so if you have a biomarker that, yeah, shows that the kidney's damaged, but, oh, it could be the liver, it could be the heart, it could be the brain, it could be some other organ, then it's not going to be very useful for us. So we'd like a kidney-specific marker. Hopefully it would reflect these very, very early phases of the injury so that it predicts something at the very beginning of the process rather than something like creatinine that occurs at a much later stage in the process, and or gives us some indication that this kidney is starting to repair. That would certainly be helpful for understanding where we are in the whole schema, and maybe prognostically, yes, Mrs. Jones, stay with us, do another 3 weeks of dialysis for $10,000 because your kidney's getting better. And we would like the biomarker also to reflect the extent of the injury. So is this a little bit of damage or is this a lot of damage? And the biomarker should correlate with changes in the pathology or changes in the therapeutic interventions that might be applied to that animal. So that's what we would like. That's the ideal. What do we have? Well, we have some biomarkers, and this is certainly an extremely active area of investigation, not just for the kidney, but for all kinds of organ systems. And we have, for the kidney, we've got a series of biomarkers that are ordinarily filtered by at the glomerulus, and then become useful with detection in the urine or detection in the plasma because they're modified subsequent to filtration by the tubular epithelium. So if the tubular epithelium is not modifying modifying mostly by reabsorption, these filtered substrates, then they'll show up in differential quantities in the urine or in the plasma. Probably maybe even more exciting would be tubular-specific biomarkers, some molecules that are actually generated by the tubular epithelium, so that when that tubular epithelium gets irritated, angry, pissed off, or injured, that they become exposed to reflect that injury. And there are a variety of these that have been evaluated and continue to be evaluated to help predict this process. In human medicine, probably some of the poster children molecules would be kidney injury 1, KIM1, or NGAL, that have received a lot of interest and a lot of potential validation. I'll just tell you up front that we've looked very extensively for with the assays that are currently available for KIM1, and we can't get the dog to be reflected by this assay. So we sort of took KIM1 off of our list, even though that's one that's been highly touted for predicting early disease in humans. So let me show you some data from a few of these biomarkers that we've had the privilege of collaborating, and we have some of the collaborators right here in the audience that have given us a lot of encouragement and enthusiasm that maybe in the very, very near future we might have some better diagnostic and predictive markers for this kind of injury. And so we're going to be mostly looking at some of these. There's a lot of literature already on these filtration or these markers that are delivered by filtration. We're going to look at some markers now that pretty much are generated by the tubular epithelium per se, and that are in development for evaluation of usefulness of biomarkers, and let me just show you those data. One of them, and again, as we SDMA is a marker that is getting a lot of recognition and excitement for predicting events for glomerular filtration that may be more specific and more helpful compared to a marker like serum creatinine. So we're very excited and interested to look at SDMA as one of these markers. But as a filtration marker, if we look in our gentamicin population, most of these data that I'm going to show you are going to be a study that we did in normal dogs that were exposed to gentamicin, and they were given gentamicin until their serum creatinine increased by 50%. And then the dose was stopped, so we wanted to get early disease in these animals and not get them so injured that they wouldn't recover. And so it was a little bit more severe than Iris would have predicted. Iris would have said, you know, you've got kidney injury when the creatinine goes up 30%. Then we extended a little bit, so a 50% increase in creatinine. And then these dogs were mostly sampled twice daily, so we had morning and afternoon samples, and have a lot of time resolution then in the data collection. And so here's serum creatinine in the blue, and serum creatinine, I think, identified the acute kidney injury by this 50% increase criteria at about day 14. And I don't remember what day SDMA, but you can see that SDMA and serum creatinine for this model of disease look very similar, and they're probably giving you very similar kinds of data. And SDMA, although it's going to probably be very useful for other kinds of kidney disease, as an early marker of acute kidney injury, it didn't seem to be very helpful. The next molecule that we had opportunity to look at was serum inosine. Inosine is a molecule that's derived from proximal tubular epithelia. It's an intermediate in purine metabolism that's generated from the deamination of adenosine in the proximal tubules by adenosine deaminase. And so it's linked up in this whole AMP, ADP, ATP. It's linked up with energy metabolism of the cell, and for that reason, Jesus seemed really exciting. If you got something that shows that you've gotten rid of all your energy and you can't restore it, then that epithelial cell is going to be kind of toasted. And so it ends up. This one is a serum biomarker, and so you would predict that it would change in the serum as there was a change in its constitutive production. And so compared to a lot of the other biomarkers that we'll be looking at, inosine is a marker that we identify the injury as it drops, not as it accumulates in the sample that you're collecting. So in this particular dog's serum inosine then was up here in this range, and I've also plotted the data, the simultaneous data in this particular animal for serum creatinine, and you can see that with the onset of the injury, serum inosine concentrations dropped dramatically in the first few days, very predictably and very identifiably, and then stayed kind of in this low range until there was some recovery. And in this case, this marker right here identifies the day that the drug was, I think this identifies the day the drug was stopped in this particular animal. And once the drug was stopped and the kidney started to repair, then we can see that there's some recovery of the serum inosine in this patient. If we look at this early marker window right here, this is kind of, it looks a little cluttered here, but if we sort of expand this a little bit and now look at this first week to 2 weeks, you can see that compared to serum creatinine, which did absolutely no change after 10 days worth of exposure to gentamicin, serum inosine was very predictive in the first couple of days that this drug was damaging these proximal tubular epithelial cells. And so this biomarker would tell you early on that look closely at this animal, potentially modify your drug strategy because the kidneys are getting banged on the head. These are other data that have come from IDEXX using a different model and looking at this was Dicromate administration, which is another nephrotoxicant. And again, in this model, compared to SDMA, which is going to be this more long-term marker of glomerular filtration, you can see that inosine concentrations dropped very dramatically, very precipitously in this dog, or this group of dogs, and stayed low until there was some recovery of the damage, in which there was regeneration and recovery of the inosine concentrations. Dr. Yerramilli's here in the audience, and these are his data. When I saw this, I just got my little heart went pitter-patter, because this just really looked really very, very encouraging, and something that would predict maybe early damage as well as potential for recovery. Another one that is a very attractive biomarker is urinary clusterin. This is apolipoprotein, a big molecule expressed in proximal and distal tubular cells, and its claim to fame is it becomes overexpressed as the tubular epithelium is injured. And so this is a marker that we're going to expect to increase with injury because it's becoming overexpressed. The changes are more profound when you look at it in the urine than if you were to look at the serum accumulation of this compound. And so this is really neat. You know, the injury's in the kidney's making urine, downstream all of this stuff is in the urine. So it really has the potential to be quite a sensitive and specific predictor of these cells. Its role in the kidney is probably to help protect these cells from apoptosis and other kinds of cytocellular stress. And so it makes sense that when the cells are getting stressed or injured or damaged, that it's going to come up and say, I'm going to fix you, I'm going to try to protect you. And so that's good logic and strategy for this biomarker to be useful and predictive in these kind of circumstances. And we look at urinary clusterin, and we put this line here as probably the boundary for between what's probably normal and what's abnormal. Again, compared to serum creatinine, we can see that the clusterin levels increased fairly dramatically over time. There's some noise in this that maybe Dr. Yerramilli has some better understanding of, but this may be waves of damage or in the kidney. But clearly we see very early identification, particularly compared to our traditional marker like, I thought I had a blow up of that. But you know, by just a few days of the injury, this marker has already come up above the upper limit of the range, and could be predictive and suggestive that you've got damage going on. Another one that we studied is urinary NGAL, and as I mentioned, this is a biomarker that is getting a lot of interest in human medicine. This is part of the lipocalin superfamily. It's a marker that's produced by proximal tubular cells, so it's produced by the cell that's of interest to us. And again, its expression is enhanced by inflammation or injury to the cells. Probably a little bit of a detractor for NGAL is that it's also expressed as a result of inflammation from the inflammatory cells, and so if you have inflammation, particularly if you're looking at urinary concentrations, you have other kinds of urinary inflammation, that it might not be as specific for proximal tubular injury. But when we look at urinary NGAL, and here's our this is now a group of dogs, the same group of dogs, so this is the collective data from all of these dogs when we compare to creatinine, which is this curve. Again, urinary NGAL came up, and we're going to expand this range because with this scale, it doesn't look like there's much going on here. And you know, and out at about 5 or 6 days, then we're starting to see things happen. We've got this big spike here, but we'll go and look at this area a little bit and maybe expand the range here a little bit, and we'll see that the NGAL is going to be one of these markers that looks like it will be very early and very predictive. We looked this paper now is printed. I think it came out about the end of last year in JVIM, where we wanted to look at the specificity of NGAL in dogs for acute kidney injury, and so we compared to control dogs, dogs with lower urinary tract inflammatory disease, dogs with chronic kidney disease, animals with acute kidney injury, and these are animals with naturally occurring disease, so this is not experimental animals now, animals that we identified with naturally occurring acute kidney injury, that urinary NGAL was very, very specific for acute kidney injury, and also was able to, for all grades of AKI, but also was very, very specific about picking up these early grade 1 AKI patients. This is urinary NGAL again, and I think we have well, anyway, NGAL in this study, this is now our gentamicin study again, and urinary NGAL was able to pick up the AKI at about 8 or 9 days compared to day 18 for this collective population of dogs looking at serum creatinine as your biomarker. So 10 days earlier than you would have predicted the injury by creatinine, urinary NGAL predicted the injury at about day 8. And maybe with more closer look, you might even get urinary NGAL to look at a couple of days earlier than that. And again, here's urinary NGAL compared to urine-specific gravity, and its urine-specific gravity is still good, but NGAL is going to potentially be a very useful marker for us. Now, if we look at urinary Clusterin versus the NGAL creatinine ratio, and again, I'm going to expand this early phase of the disease here, that we can see that both of these markers are coming up at a very early stage, within days, 2, 3, 4 days of the injury. We're getting increases in these two markers, and they have the potential then to be very helpful and useful for us. So in putting all this together and summarizing it now, particularly if we had a panel or we had a spectrum of biomarkers that we could use to identify or to evaluate kidney injury, we've got some potential in urine-specific gravity, maybe in urine in inosine concentrations that may be able to pick up the injury in the first 2, 3, 4 days of onset of the problem. Urinary specific gravity is not going to be very helpful because these animals are on fluids and they're on drugs, or you don't know what their previous specific gravity was. I mean, it's an early marker, but we would really probably put a lot of emphasis on something that is more specific, and it looks like, you know, a marker like inosine would give us this time sensitivity right here. Then we've got another series of biomarkers, NGAL and Clusterin, which are probably going to come in and be very, very useful at perhaps picking up between 3, 4, 5, 6, 7 days worth of injury. And then we've got our traditional markers, creatinine, SDMA, iris grading, that are all still going to be useful, but they're going to identify animals at a much later stage of disease. And so with a spectrum of evaluations or a spectrum of biomarkers, particularly if we could include one that might also be potentially useful at looking at the recovery phase, then we would have a very, very useful understanding of where this animal was in its kidney injury and perhaps which direction it might be heading. That's all I got to say.
Questions?
we didn't measure GFR in our experimental dogs. We measured GFR in the 10 dogs that I showed you earlier that had mostly lepto. We measured GFR in those dogs, and GFR was a predictor of recovery too. So the animals that recovered had an increase in GFR within the 7-day window of time we looked at. The animals who didn't have a change in GFR didn't. But GFR is not going to be a very practical test for you, you know. So even though that might be useful, and maybe as a gold standard, it's not going to have any clinical utility because it's cumbersome to do. You're not going to get the kind of turnaround in the information you need, and it's difficult. I mean, GFR measurements are difficult to do accurately and predict accurately. So I think don't put your coins in that first.
Yeah, we've just been having a lot of issues with what people traditionally think of as quality of our to each other, and there's a lot of question in that regard. So I'm just curious if anybody else has any data. My creatinine, can my creatinine really hold steady with regard to metabolic rate?
Don't have data on that, but love to see it.